Thank you very much. Good morning, everyone. This lecture will certainly serve as a summary of what we have talked about earlier today. I thought I'll give you some scary figures first, that we have 39 million blind people in the world and visually impaired, and 246 million moderate to severe visual impairment. And these numbers will rise to 75 million blind and 200 million visually impaired by the year 2020 if we do not increase the number of ophthalmologists and surgeons. Blindness worldwide, 58% are age 60 or over, and so forth. Now, the cataract is the main cause of blindness in the world, 47.8%, glaucoma come next, and so forth. I was asked earlier about the prevalence of astigmatism. 35% of cataract patients have more than one diopter of astigmatism. Your refractive lens exchange patients will probably have even more. So, how much astigmatism is clinically relevant? In monofocal IOLs, one diopter or more will certainly cause distortion. It's no question about it. Now, if we come into the multifocal IOLs, half a diopter or even less than that will cause a decreased performance at all distances of that lens. It is not as easy as this with the different types of astigmatism: myopic astigmatism, hyperopic astigmatism, or mixed astigmatism. I wish it was that simple, but it isn't. Now we have to take into account the regular astigmatism with a rule where the vertical meridian of the cornea is steeper. We have to take against the rule where the horizontal meridian of the cornea is steeper. Now, here comes the first trap for you. Irregular astigmatism, whatever you do, please don't touch it. It will just not work. Even with multifocal or multifocal toric, do not implant any toric lens on that one, because it will be so deep in trouble so you would not believe it. Trap number 2. How does the incision affect corneal astigmatism? There is a prospective, a very nice study by Masket and al., a prospective contralateral study of 22 eyes, one surgeon. One eye was received a 2.2 incision size, and the other received a 3 millimeter incision size. And the mean change in magnitude of keratometric astigmatism was 0.1 diopter with a 2.2 incision and 0.3 diopters with a 3 millimeter incision. Now there is, of course, a trade-off of this. The smaller incision size you have, the more prone the patient will be to develop PCO. And here we have a very nice topography slide with 2.4 millimeter incision. We are inducing here 0.2 diopters of astigmatism after surgery. So, before the surgery, patient selection and preoperative assessment are critical to surgical success. With toric IOLs, it means increased share time. The preferred candidates you've heard about before, if they have a vision compromising cataract, astigmatism, and interest in reducing the glass wear, it is a good patient. And, of course, if the eye is healthy enough. The quality normally of patients receiving a toric lens are excellent. So your pre-op workup must need a lot of attention, and you need to get the corneal topography, as said before, to determine whether the astigmatism is regular or irregular, and you also need to have more than one measurement method for your keratometry, because you are correcting this astigmatism, not the total. So do not implant patients with irregular astigmatism. It cannot be stressed enough. So there are 4 surprises to be avoided here. And beware of the wrong cylinder. Commit to treating only the keratometric cylinder. And document the keratometric astigmatism by at least one reliable method. You can even take out your old keratometer and use it, plus a topographer. 2 excellent tools to determine the astigmatism. And beware, of course, of the induced astigmatism. We talked about this before. We have heard almost all the speakers refer to the astigmatism calculator created by Warren Hill. Now, a tip here is that try about 20 or 30 cases and put your values into this calculator, and you might end up with a surprise, I tell you. So again, beware of the wrong axis. Hang the printout of the Acrisoft Toric IOL calculator too, where it can be seen from the microscope. If you sit superiorly, hang it upside down, and if you sit temporarily, hang it sideways. Failing to do so, it's easy to fall in the trap to get the lens 90 degrees off. And again, take care of pre-marking. Always mark with the patient sitting up, because in the supine position there might be a cyclotorsion, that's a rotation of the eye, so that you will notice that. And make sure that all viscoelastic is removed from behind the lens to keep the lens secure in the capsular bag and to minimize rotation. So what went wrong? It is important to understand the reasons for the residual astigmatism before trying to correct it. Our top 4 errors: pre-op measurement errors, incorrect marking of reference points on the cornea, incorrect placement of the IOL, or failure to take into account the impact of surgically induced astigmatism. So there are some clinical pearls for troubleshooting with toric IOLs. The outcomes, the current state, this is a very actual report from Al et al. At 2012 and G et al. Also at 2012. 95% had a visual acuity of 0.5 or better, and 62% had a visual acuity of 0.8 or better. Not very impressive. The pre-op results was, pre-op cylinder was from 1.5 to 4.5 diopters, and the post-op cylinder was 0.42 diopters. We've heard an excellent talk before from one of the speakers of the impact of if you have the wrong cylinder. So there is undercorrection, and why is this? The future, I think we have to look into another area as well, because we are treating a cornea, we are touching the cornea, we are disturbing the tear film of the cornea, and irrespectively of what you say, more or less 100% of all these patients do have a surface problem, that is to say, an induced dry eye, surgically induced dry eye. A tip here is, if you have your patients, give them wipers to reduce, if they have any blepharitis, 2 weeks before the surgery, and give them artificial tears also with these wipers, because that serves 2 purposes. You have a nice wet cornea when you see them, and they already know how to use the eye drops, because the main complaints of many of your patients is I am not sure I got the drop into the eye. You recognize that, I'm sure. So healing after surgery is another problem. If people have a tendency to rub their eyes, this will disturb the refraction. We could have a capsule tension that will result in torsional rotation, that is, or even a tilt of the lens. And a pupil decentration will, of course, cause off-axis errors. So the management, you can say, is pre- and post-surgical errors. Exact source of error, best treatment of options, preparation for post-op treatment. So what should I do? IOL, reposition, exchange, keratotomy, LASIK, PRK, or even an add-on lens. Here again, these are the effects of aberrations and cylinders changes, and you also have to take into account here that I haven't mentioned before, the non-equicentripetal forces. That's a pressing of the capsule onto the lens, and misalignment and off-axis we all know all about. So what should I do? IOL, reposition, exchange, keratotomy, LASIK, PRK, add-on lenses, or even spectacles. By that I summarized, and beware of the aberrations. Thank you very much for your